Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions. Also, a big thanks to Justin Kugel for his video editing, support, and creative contributions.
Thank you for joining us on Decoding DX. We keep learning so much through this experience, and we're so glad that you're learning alongside with us. Now, let's get to the episode. All right, welcome everyone to Decoding DX. So, Zach, we've seen your face before. It's great to see you again. Tell us who you are, where you're at, and something about you that does not involve medicine.
Oh, goodness. Okay. I messed up on this question last time thinking about it. All right. So I'm Zach Duarte. I'm an M3. I am on my neurology rotation. I absolutely love it. And something about me that's not involving medicine, I love to cook, and that's like my pastime and hobby.
That's awesome. Definitely comes in handy in med school. Dr. Abebe, what about you? We've seen you before. You're tried and true famous around here, but tell us who you are, where you're at. Something about you does involve medicine.
Yeah, I'm a clinical educator at the University of Kansas Medical Center and one of the core faculty at the internal medicine residency program. I am a diehard, dedicated yard worker, if you will. I like working on my yard. I don't even hire anybody. I get teased a lot, but that's my way of, getting things out of my way, and 1 hour, 2 hours, sometimes 3 hours of hard labor kind of rejuvenates me.
Awesome. Thank you guys so much. We have another awesome case tonight. John will be our kind of moderator, leader through all this, and I'll let him go ahead and take it away.
Alrighty. So just a reminder that this is a real case, but it is information is changed, so it is not reflective completely of the patient to protect their identity. So without further ado, our first bit of information. So our chief complaint is fell down and shook at work. So we have a 51-year-old male. He presented to the ED by EMS because he lost consciousness while at work. He works in sewers, and when he started going up the ladder in a manhole, he kind of felt like he had difficulty using his hands, and his coworkers had to grab him and pull him up. And then once he got out of the manhole, he started convulsing. They said that it went on for about a minute or so. They said it was symmetrical full body shaking. That's what a quote from one of his colleagues. During that episode, he was non-responsive. It was symmetrically moving. His eyes were open. He had urinary incontinence, but no tongue biting. After the episode was over, he regained consciousness, but he was confused and actually turned out to be a little agitated. He got 5 milligrams of midazolam on the way in the ambulance because he tried to do a swing at one of the EMS people. But when you're talking to the patient in the ED, he doesn't remember anything after he started going up the ladder. He just remembers waking up in the ED. So this kind of thing has never happened to him before. He hasn't been sick recently or felt like he was getting sick. He's never had any head trauma currently or in the past. And he's never had any meningitis or other CNS infections. He also doesn't have any family history of seizures or blacking out or anything that he's aware of. A quick review of systems was positive only for fatigue and kind of a chronic cough. He doesn't have any past medical history that he's aware of. He hasn't seen the doctor in a really long time, though. He says the last time he's probably seen the doctor was maybe 20 years ago. His family history only significant for his mom had breast cancer when she was in her 80s. Otherwise, family has been really healthy. So his social history, he is a married gentleman to his wife. They have 3 kids. He's a former Army sergeant. He served in Afghanistan. He smokes 2 packs a day for a total of 36 pack years. And he reports to you initially that he drinks about 5 beers a night. But, you know, when you're talking to him in the ED, you see his wife's kind of eyeing you, and she pulls you aside as you're leaving the room and says, yeah, I think it's closer to like 10 to 15 beers a night. And she's actually pretty concerned about his drinking and his smoking, and it's been getting worse recently. So go back, and I went back in the room, talked to him. He admits that, yeah, it's probably closer to that, but he's never had any issues with withdrawal that he's aware of. He stopped in the past for multiple months. And his last drink was about 24 hours ago at this point. So it was less than 12 hours after when this incident happened. And he had never had any issues in the past of replacing meals with alcohol or anything like that. And he doesn't take any drugs, or he doesn't have any medications, and he doesn't have any allergies that he is aware. All right. So that's a lot of information. But starting off, what are you thinking about with this presentation thus far, Zach?
There's a lot of things that this could be, but it seems like there's a good chance he's had a seizure, some of the things that you described. That would probably be my first area that I'd go to, but there's a possibility that he could have had some sort of possibly even like a stroke or maybe something else. So there's a chance that he could get like a CT scan like real quick in the ER, just to rule out anything like that.
So oh, sorry,
okay.
Go ahead.
I mean, other things that can cause seizures, if he did have a seizure, I mean, you're probably going to get like a blood sugar check real quick. And then like if you got a CT, that would kind of, any major structural lesions would kind of rule in or rule that out real quick. And then at some point, he's probably going to go for MRI and EEG if you're concerned for seizures.
So if he does in fact have a seizure, I absolutely agree. What other things that you think of can cause loss of consciousness? Like what's some other things in your differential for loss of consciousness?
Loss of consciousness, in this case, it would be possibly seizure. Any like metabolic things can cause loss of consciousness. Actually, one second.
Dr. Abebe, are there other things on your differential for loss of consciousness when you see this coming into to the emergency department?
Yeah, so just this is a very interesting case. So you have a young, otherwise healthy male who has no past medical history other than probably smoking and kind of a shady drinking history, who had a sudden loss of consciousness, preceded, it sounds like, with no prodrome symptom and seizure. So the question is the seizure the product of some sort of trauma versus underlying issue that we're not aware of? Or is this loss of consciousness a primary event and the seizure is more of a mimicker? So when someone loses consciousness, majority of the time, I think of neurocardiogenic syncope. He is a drinker, maybe he is dehydrated and hasn't hydrated himself very well, and maybe was hypotensive. We don't know what his background history is, and we kind of think of other reasons for someone having orthostatic hypotension. Maybe he's a diabetic, we don't know. And that may be one reason why he had that. The other important, so the two are orthostatic hypotension and neurocardiogenic syncope. the fact that it's a patient who hasn't had no history, but having said that he's a smoker, we should also think of some sort of arrhythmia, so cardiac cause. This is like in the broad category of reasons for someone to lose consciousness. Could it be a structural problem that we're not aware of because we haven't gotten the physical exam yet? One of the things you will find out in patients who have cardiogenic origin for syncope is they usually don't have prodrome and things happen suddenly, especially if they have arrhythmia. Any valvular disorders, hypertrophic cardiomyopathy. He's young, very unusual to just have the first episode without having any other symptoms of hypertrophic cardiomyopathy, but it could happen, especially if he's exerting, and they're usually volume dependent, and that can actually be a reason for that. Pulmonary embolism, this is, he's a smoker, maybe he's not moving well prior to this, I guess, could be a reason for that. So those are main things that I would consider. And mimickers, like we talked about, sometimes they would call them mimickers, or they could be miscellaneous as part of a cause of loss of consciousness. Like Zach said, maybe he had kind of a mini stroke or stroke, or maybe this is a primary seizure disorder. But like I said, this is his first episode, and usually you have to look for triggers. Like he said, hypoglycemia, maybe he was hypoxic, and so forth. I think those are the things that primarily come to mind. But when someone comes in and have sudden loss of consciousness, like any other thing, I would like to rule out primary cardiopulmonary disorders like pulmonary embolism, myocardial infarction, aortic dissection. But the fact that he recovered, I don't know whatever happened, the fact that he recovered pretty quickly refutes that possibility. But I think there are a lot of considerations in this case. If you're going the route of seizures, then you have to look for, like I said, precipitants. Maybe he's withdrawing, but he didn't have any withdrawal. But if I have to look for, it's either electrolyte abnormality, a nutritional deficiency of some sort, or dehydration or intravascular volume depletion as a start.
That was an excellent analysis. Thank you, Dr. Abebe. So let's go a little more information. So now we're taking a look at him on physical exam. His vitals, his temperature is 36.9 degrees Celsius. Blood pressure was 138/90. Pulse was 90. Respiratory rate was 16. And his O2 sat was 96% on room air. You also got orthostatics on him, and they were within normal limits. When you look at him, generally, he's not in any acute distress. His ANO ×4, sitting there resting, kind of has that look of, why am I sitting here, as you may see with some of your patients in the future. He does not have any scleral icterus or other stigmata of alcohol disease that you're aware of. He has dry mucous membranes in his mouth. Respiratory, he's got clear auscultation bilaterally. You don't find any additional extra sounds. His cardiac exam, you do a full cardiac exam. He's got regular rate and rhythm. You listen very closely, and there's no murmurs. He doesn't have any peripheral edema or other signs of issues with cardiovascular system. On abdominal exam, he does have mild hepatomegaly. And then you do a full neuro exam, completely intact, cranial turfs 2 through 12 intact, strength throughout 5 out of 5, no change in sensation. Also, no tremor or signs of withdrawal. And from a psychiatric examination, he's not agitated, or no real signs of withdrawal, like I mentioned, and no hallucinations or other signs that, some of those questions that you'd be kind of ruling some of those things out. So Zach, is there anything in that kind of exam that kind of helps you rule out some of what we've discussed thus far, or make you think more so this was a seizure?
I mean, the exam is pretty clean, or there's not much there as far as I don't know. So like if we're concerned about cardiac causes, I mean, just on your cardio exam, like regular rate and rhythm, there's no edema suggesting some sort of heart failure. On his vital signs, I mean, he certainly could have a PE, but those don't necessarily point directly in that direction. I mean, his respirations are 16, his SpO2 is fine, stuff like that. So it doesn't seem to me like he's in a lot of acute distress. So, I mean, if he was having an MI or something like that, maybe he would be like cool, pale, and diaphoretic. It doesn't seem like that. He might be a little dry because of the dry oral mucosa. And then, I mean, the mild hepatomegaly, I mean, it's kind of to be expected since he seems to have some alcohol use disorder. So I'd say the exam here it's not specific for anything. And it kind of points me maybe a little bit away from cardiac causes, but it's not for sure at this moment.
Yeah, absolutely. And we kind of were also thinking about maybe stroke in addition. And, he doesn't have any focal neurologic deficits that would make you think, oh, he could have had a TIA, obviously still, but, there wasn't like he has something that neuro strikes you there. So if you were working down in the ED at this time, you kind of had started talking about some of those labs, Zach. What labs would you want to get on him, and any additional imaging?
So the labs are going to be like the CBC, CMP. If we're concerned about cardiac involvement, there's going to be like a troponins, if you're concerned about an MI. And then also going to grab an EKG for that. So on the EKG, you might be able to see the ST elevation or maybe right heart strain if you're concerned for a PE, or like any weird arrhythmias that you might be currently having. Other labs, let me think. CBC, if you was maybe concerned for some infectious cause or something like that, might show something like that. Not for certain though.
I think that's a good start. And you also had mentioned CT head earlier, and anybody who comes in a picture like this is probably going to get one in the ED as well. So you got a CMP and some additional labs, so I'll go ahead and list those off. So he had a sodium of 122. He had a potassium of 3.3, chloride of 88. A bicarb of 20, a BUN of 6, a creatinine of 0.72, glucose of 100, and then he had an albumin of 4.1, AST of 32, ALT of 12, magnesium of 1.9, and then you also got a point of care lactate, which came back as 5.5. CBC, hemoglobin was 13.3, white blood cell count 5.5, platelet count was 257,000. The differentials were all within normal limits. You also got a urine drug screen on him, making sure you're not looking for something like he's on some stimulant or something like that. And that was positive for benzos earlier only, but he received that on the way in the EMS. So that's where that can be accounted for. He got a CT head that showed no acute intracranial hemorrhage or mass effect, and then it also showed a small, non-aggressive appearing osseous defect in the right middle cranial fossa floor, which was most likely to reflect a sphenoid wing cephalocele. So when I first read that, I said, I don't know what the heck that is. So it's just any kind of osseous defect that any kind of CNS tissue can go through. That's actually very, very common, and it's usually just a kind of an artifact that you see. But the radiologist that saw it said, if you're concerned about a seizure, this might be a focus of a seizure, so this might be worth getting additional imaging on. So there's some abnormal labs there. So Dr. Abebe, when you see this lab profile, what do you start thinking about when you see, I guess, that? I mean, I think the big thing that kind of stands out is probably that sodium. So what do you think about when you see this kind of picture?
I think just to go back, comment on the physical exam.
Okay.
Key is a patient who had syncope, otherwise healthy. I expected a little bit more on the exam. I expected him to be probably hypotensive, a little bit tachycardic. Didn't see that. I don't know what his physical build is. Maybe a cachectic person who probably has been drinking for a while, and he has mild hepatomegaly. It could be due to his chronic alcohol use. But as you pointed out on the lab, as we'll be talking about, that probably does not correlate. But I would say it's double. AST/ALT is double, but within the normal range still. But now going back to the lab, when I see a low sodium, a low chloride, and a BUN that is low, it makes you think of few things. I don't know if the lactate is something that you would rely on a patient who just had seizure, especially when you look at the volume status does not correlate well with a high lactate. So I'll probably put that aside. So when I see a sodium that is low, for all practical purposes, clinically significant hyponatremia is due to hypoosmolar hypovolemic hyponatremia generally, or I would rather say hypoosmolar hyponatremia. You have hyperosmolality or normosmolality, but when we talk of clinically significant one, we are practically talking about hypoosmolar hyponatremia. Then I look at their volume status. Is this patient volume depleted versus volume overloaded, or is this patient euvolemic? This patient probably leans in between euvolemia and hypovolemia, because like I said, he's not orthostatic, he's not tachycardic, except for his slight dry mucous membranes. There is no other evidence of significant volume depletion. Having said that, you also see a potassium that's low. Very rarely do you see potassium that's low. So in a patient who's alcoholic, I think of two things. Maybe he's not eating and drinking or replenishing his potassium. The other is I want to make sure that his magnesium level, because he's alcoholic, is not low. The other thing I would go with euvolemia is remember, although he's a patient who has no past medical history, he's a chronic smoker. So in a chronic smoker, and if it's a euvolemic, could this be a paraneoplastic syndrome in the form of SIDH? That's one thing I would be considering. The other is if he's euvolemic, and if he's a chronic drinker, could this be a beer potomania, someone who's been drinking and he had a sort of a reset osmostat where his sodium has come down. One thing striking is, it probably took some time for his sodium to go down 122. Maybe he has been in the middle, and then now something happened and make him dehydrated, and that was the reason for his seizure. I would be interested to find out what his ketone level is going to be, because he probably hasn't eaten. Maybe he has starvation ketosis, because it sounds like his blood glucose is fine. So that's one thing I would be considering. So I would think of paraneoplastic syndrome, beer potomania, and primarily related to the fact that he hasn't been drinking. And BUN of 6 is a very good indication of probably an SIDH picture, but having a normal creatinine. So things I would be looking for would be that. And as you've said, his anion gap is slightly kind of on the above range. Like I said, could this be due to starvation ketosis? So like I said, I probably would like to get a urine ketone. But as you've said also, the lactate was 5.5. So maybe, I wouldn't be too alarmed about the lactate because it does not currently correlate with his picture. I think that's what I would say for now. And then the other thing I was going to comment on is rarely does CT scan be very helpful. In his case, maybe it is one thing, you're not looking at the cause, but the effect. Maybe because when he fell, maybe he had trauma and but the other thing also is, this is a patient who's chronic alcoholic, and patients who have chronic alcoholism have a low threshold to have subdural hematoma as opposed to other patients. So you can take it the way you want it.
Mm-hmm. Wow, that was a very, very good analysis. Thank you, Dr. Abebe. When we saw these labs, lots of kind of red flags went up. In addition to the CT imaging, mostly because it's the potential source of seizure, but now we have a potential etiology and saying maybe this is a toxic metabolic picture, and that could have provoked maybe an underlying focus of epilepsy, that he just has not had a seizure up to that point, and he hasn't had an electrolyte or alcohol related withdrawal related, lowering his seizure threshold so that he could actually have a seizure. So after we saw that lab, we started to get a little bit more of the hyponatremia workup. So that included serum osmolarity to look for the hypertonic, hypotonic, or the isotonic, and looking to see if it was that true hypotonic, what you think of as the classic excess total body water. And then we also got urine sodium, and at the same time got urine creatinine as well. One question that I had for you, Zach, do you think in this situation that you would consult neurology while you're likely going to be admitting this patient?
It's a good question. I don't necessarily know that you would. I feel like that's one of the things. If I were asked an internal med attending or something, they're like, we can manage this ourselves. Like, we don't need neurology. I feel like that's the right answer here. And I also don't necessarily think that this is epilepsy. If you had more after this, then you would start going down that road. But I think the internal med docs would say no.
I would agree. I will say that our attending did in fact consult neurology, but only for this one express purpose, is because they did not feel comfortable knowing whether we needed additional imaging based off of that CT finding. And so that was we had that discussion on rounds at the time and said, I think we have an etiology. I think we know he probably had a seizure and it's probably related to a sodium. We can correct that. We can manage that. But there was that background thing in our head saying, well, what if this is actually a focus of his seizure? Should we consult them to say if they think that we need to get additional imaging? So that's kind of in the back of our head. So that'll come up in a little bit here. So some of the sodium labs that came back. So his serum osmolality was 267. So that came back as a hypotonic or true hyponatremia picture. His urine osmolality was 320. And so since I don't look at those often, I'll just say that's high. And then a urine sodium came back as 32, which also is a little bit high. Like Dr. Abebe had mentioned, his volume status was kind of hard to tell. He somewhere in the middle of a euvolemic to maybe a little bit on the drier side hypovolemic picture. So the things that we were thinking about is either an inappropriate ADH picture versus hypovolemic hyponatremia, dehydration kind of picture, because he does work outside. So in this situation, we were kind of thinking based on those labs that it kind of was more consistent with an inappropriate ADH state. Because if we kind of look through some of those labs, he had high urine osmolality, meaning that ADH is working to concentrate his urine inappropriately, because really you should, if you had an appropriate response in that situation, you would be trying to remove your excess free body water. And then at the same time with that urine sodium, since he's not on any diuretic or any other reason for his urine sodium to be increased, that being on the higher range means that the renin-angiotensin aldosterone system was working, and it was decreasing your aldosterone production, meaning that you're wasting more salt essentially. So that kind of reflects like a pseudo normal physiologic state that we could explain based on kind of his presentation. However, it's really not an obvious thing, like Dr. Abebe was saying, that euvolemic versus versus hypovolemic state. It's not really obvious or something. And there's been lots of studies that have shown that our physical exam skills on that are not very sensitive or specific, really. And you will give a big group of like nephrologists who this is what they do for a living. They're really good at electrolyte balance and looking at edema and all these things, and it's kind of all over the board. And it's just one of those things that you feel like you wish you'd be better at that, but we're not good when it's not crazy hypervolemic edematous 4+ pitting edema necessarily. So when we're thinking about starting to manage this patient, Zach, do you think we admit them first and foremost? And if we think you admit them, why do you think you admit them? And do you think we need to admit to the ICU versus the floor?
He's definitely getting admitted, for sure. So a reason why, I'm sure there's some good scoring systems out there that'll give you a reason why. I think, I might be citing the wrong ones. Are CURB 65 one, or is that for something else? Is that pneumonia?
That's for pneumonia.
Okay. There's a lot of good scoring systems, I'm sure, for this. I can't remember them, but just off of hand, he had a seizure from hyponatremia. I'd say he needs to be admitted. ICU status, I don't necessarily think that's the case, but I'm sure there's a scoring system for that too. That would just be my impression off of hand.
I can help you here. Generally, there isn't a good reference tool to say you have to admit this and that. Most of the time, it's clinically based and the setup you're in. Remember, an ICU setup in a rural community or elsewhere is more of what we take care of on a day-to-day basis. So it depends on the comfort of the physician and the nursing, especially nursing, the care available to determine whether a patient needs to be in the ICU versus non-ICU. There is, if I remember right, it's called a San Francisco, I forgot, I think it's, if I'm saying the right one, I think it's called San Francisco. It's whether patient has heart failure, whether they have low hematocrit, and I think if they are hypotensive or if they have shortness of breath, these are things that you would consider as primary reasons to admit patients. But in general, the way I see it, this is hard to remember. I think it's the comfort level. I think if I have a patient who I know he's elderly, above 70, multiple comorbidities, if they have structural disease, or if let's say they are hypotensive, if their hemoglobin was low, and if you're really concerned about, or if they have a recurrent syncope, these are things that would lead me to admit them. Majority of the patients that we admit for observation do not warrant admission. I think I'll throw it out there, because you would be able to differentiate the ones that you feel need to be admitted or not by just doing history and physical exam, because in majority of the time, I think it's 50% of the time, you'll be able to differentiate the cause of syncope right away. But if you're not, then that's probably a concern for you that you need to admit these patients. Check, I think it's San Francisco, but check it if that's the correct one, but I haven't used it for a while.
That's correct, Dr. Abebe.
Is that right? Okay.
Mm-hmm. Yeah. And so, yeah, so that was kind of the thing that we thought about with this patient is, like you had said, Zach, clinically he looks okay, but with a sodium of 122 and he just had a seizure, you think that that's probably related, and so we probably want to correct that. And the question of ICU versus floor status, we had thought a lot about that as well, and the big thing that we talked about is how we're going to correct that. And so the treatment of choice for severe symptomatic hyponatremia is hypertonic saline, or 3% saline. And that is not something that you would be running on the floor, at least where we work. And so the question that we had to come up with is, is this something that warranted hypertonic saline? And the conclusion that we came to was we didn't actually decide that we needed hypertonic saline, at least initially, because A, we weren't sure of his volume status, and so I'll talk about that in a second. But B, he was not continually seizing. He was not having any neurologic symptoms. He was not altered. We didn't see anything else on exam that says, he warranted needing rapid correction at this point. And Dr. Abebe had mentioned earlier, with the sodium that low, we didn't think that this had just happened overnight. It probably had chronically been going on for some time. And so that was kind of the things that we were thinking about. So our next steps that we did is we're going to start kind of correcting his sodium. And so with being unsure of whether it was euvolemic or hypervolemic, we decided to start with a 1 liter bolus of normal saline. And what that can do is that can show you how their volume status is. If their sodium responds rapidly to that 1 liter bolus, or even maybe 2 liters bolus, that shows you that, yeah, it's probably that more hypovolemic picture. But if they don't respond or get worse, then you're more thinking of a maybe a euvolemic SIADH type of picture. And so for our patient, we gave 1 liter while he was in the ED. This is all still in the ED. He had not been admitted yet, but we wanted to start correcting that if possible. And so we checked back later, 2 hours later, and his sodium had gone down to 120. So he was at 122, and then he went down to 120. So Zach, do you know why? This is a question. This is a hard question. I had to look this question up because I did not understand it at the time. Why, if you give normal saline to someone who has maybe an SIADH picture, his sodium might go down?
All right, I gotta think about the pathway real quick. If you give water in SIADH, why the sodium goes down?
Yes, can go down.
Can go down. Does that have to do with like BNP and like maybe bad? No, I don't know. I don't know off of hand.
That is okay, and that is a good answer because that is the answer that I had. Dr. Abebe, do you know?
You're muted.
Dr. Abebe, you're muted.
Sorry. I'm so sorry. I would say, one bag of normal saline has 155 milliequivalent of sodium chloride. So when you give fluid, remember only 25% of it remains in the random intravascular space. So everything else has to go somewhere. And that happens to be either interstitial fluid or your body kind of, excretes it, from what I remember. And, it becomes a solute, and, water just doesn't go. So it has to follow, it has to follow the sodium chloride or a solute. And that's probably why you lose the water with the sodium chloride. But I don't know the exact answer to that.
Yeah, and that is mostly true in the case, or that is absolutely true. But the one other aspect that I would go back to is to look at his urine osmolality. So his urine osmolality was let's see, it was 320. And so if you look at what the osmolality of a like normal saline is, it's close to about 308. So essentially you're giving him a hypoosmolar solution that he will essentially urinate out because of his ADH status. So if his ADH is high enough, he will be excreting about all of it, and so you have a net increase in your free body water for the reason that Dr. Abebe was talking about, that with how much water you get. And that's a really complex concept, but I would suggest kind of looking into that if that does not make sense, because that we could probably go on and on about that. But so now that we're getting back to our correction and how to manage sodium, really quick, so that we don't spend a lot of time on this. So Dr. Abebe, can you comment on the goals that we want to match when we're correcting sodium, and what we don't want to exceed?
So generally, they would say you shouldn't exceed from 8 to 10, or some would say 8 actually, or in 24 hours. And it depends on whether the hyponatremia is acute versus chronic. So if it's chronic, you have to be very slow. But if it's acute, I think you should be okay to do it a little bit more rapidly. But I think 8 to 10 is a number that I would take.
Yep, absolutely. And that's the goal that we had set. So we monitored our admission orders that we ended up getting as frequent BMPs. So we got BMPs about Q6, and then we had the goal of less than 8 milliequivalents change in that first 24 hours. Some additional things that we added in is we made sure that we had a AWAS or CWAS protocol in place with his alcohol use. And then we also added in folate and thiamine replacement, and also replaces potassium because that was also a little bit low. At this time, we weren't 100% sure why that was, but we thought it was likely related to his alcohol use. So additional the additional information that we had. So since we believe that this was now an inappropriate ADH picture, our management changed to fluid restriction. So we restricted his fluids to 1 liter per day. And that's where we started at. So after admission, his sodium improved to 124. We also checked in AM cortisol and TSH, because those are other causes of ADH being increased, and those were within normal limits. So at this point, we were thinking that SIADH was probably the most likely cause of his hyponatremia. Like I had talked about earlier, we did consult neurology, and they did believe that we should get an MRI of his brain and the EEG to evaluate for the cephalocele. So I'll kind of go through some of those imaging findings. So his EEG was a normal, no epileptiform movements. The MRI brain, which Brianna might be able to pull up, I'll start reading the report. It showed a tiny nodular and rim-enhancing foci in the subcortical anterior left frontal lobe and left periatrial white matter with corresponding signal abnormalities. So you'll see right there, and there's a tiny little dot, hyperintensity, in the left frontal lobe. And so the differential for that was, for us at that point in time, was metastatic disease, maybe an atypical infection, or a subacute infarct that's maybe enhancing now. But the thing that now we're starting to think about is maybe that first option, maybe that metastatic disease. And the other thing, our attending was concerned with the mild hepatomegaly and that 2-to-1 ratio in the hyponatremia, that maybe there's some underlying liver disease going on. So we ended up getting an abdominal ultrasound as well. And that showed, in addition to mild hepatomegaly, showed 2 solid hypoechoic masses in the liver. And they suggested getting a CT with liver mass protocol. So we went ahead and got the CT imaging as well, and that showed 4 hypo-enhancing hepatic masses that corresponded with the renal ultrasound masses. So at this point, Zach, is anything kind of making you start being worried, and what you're starting to maybe think a picture coming together for you?
Yeah, I mean, there's concern for cancer here now. Like, so if you have SIADH, you have to find out the reason why before you can call it, like, I don't know what the word is, like cryptogenic or something like that, or basically not, you can't find a reason for it. So you're going to want to rule out cancer. And in this case, if you find a mass on the brain or something, you're probably going to go hunt for it and see if that's most likely like not a primary mass. It's probably something like metastatic. So if he has multiple masses in the liver, you'd want to know whether those are like mets themselves, like maybe like colon cancer or something like that. I don't know, the SIADHs, like the paraneoplastic cancers, like more typically I think of like lung cancer, especially with his history of smoking. I don't know if those have mets to the liver very often, but for sure it can go to the brain. And then other things as well, like other cancers possibly can cause SIADH. Yep.
So yeah, at that point it was kind of pan scan time. So in addition to that CT of the abdomen and pelvis, we also got a CT of the chest, and that showed a large, irregular, predominantly endobronchial left upper lobe with confluent left hilar mediastinal lymphadenopathy, and then also subclavicular adenopathy, which was most compatible with an advanced primary lung cancer. So from that, we're pretty concerned about, not pretty concerned, we're almost 100% sure this is lung cancer. And so we went to get a tissue biopsy. And so we took a biopsy of the liver met, because it was kind of in an easier spot for biopsy than anything else that we had, except obviously the brain as well. So we did get that biopsy. We didn't get the results back while he was hospitalized. But at this point, it kind of came down to, okay, he's hospitalized. We're pretty sure he has cancer. What do we need to do for him while he's in the hospital? So one question that I had for Dr. Abebe, with patients that you're treating for hyponatremia, what's kind of your cutoff for saying, all right, this person, we can discharge this person? Is there a number in your mind that you have, or is there any tools that you use to kind of just make that decision?
I think, if this patient had probably chronic hyponatremia, as you treat them, you will see and reach a nadir that would be around maybe 125 to 130, where depending on their symptoms, you would be comfortable discharging them. But I think the concerning thing is you haven't addressed the primary issue, so his sodium may go back. So you have to be a little bit more kind of looking at the whole picture and find out what direction you're going to go before you actually make the decision to discharge. So I wouldn't focus just on the sodium on this patient. I would probably be concerned about what the goals on this particular patient, a young patient who hasn't had any other issues. But technically, if this is a small cell cancer, it's you categorize as limited or extensive. So this is going to be extensive, or stage 4 if it's and then small cell cancer. So this is pretty advanced cancer. So you need to have a conversation with the patient and find out what their goals are. Once you find out the goal, obviously they probably want time to think through. Depending on how quickly the sodium has returned, you might want to give them maybe salt tablet and kind of give them direction of fluid restriction, and I think most importantly, follow-up. So if you know that this patient has good follow-up, you can probably give them fluid, and you have to be reasonable on fluid restriction. Don't do things that they're not going to follow. So if you say, do fluid restriction, maybe a 1.5, maybe a good way to start, because if you say 1 liter, he probably would not do that. So do 1.5, give them a salt tablet, and kind of, I would try to experience it while they are in the hospital. So at least see, I call it like you are out, I would consider it as if you're discharged, but I would see how you do the next couple of days while, while putting you on the salt tablet or putting you on fluid restriction while taking him off, other things.
Yeah, absolutely. And that's exactly kind of, once we had this diagnosis, we kind of had to kind of sat and huddle and just said, okay, like, this guy is young. He definitely, has a cancer diagnosis. This is not going to be we're going to fix his sodium and get him out the door like someone who had some other cause. I mean, this is we need to make sure he is set for outpatient follow-up before we have him leave. And we need to make sure his family is also comfortable with the plan moving forward. So after talking to him about the diagnosis, we had the oncology team see him and the radiation oncology team see him, mainly because, we weren't going to start any treatment in the hospital, but we wanted to start that continuity of care because they would be the ones who would be managing him in the outpatient setting. So oncology talked to him, kind of talked about the treatment options, the prognosis of his cancer, and then also the radiation oncology saw him to think about, do we need to do any radiation to the head lesion, because that might have been a focus of a seizure, that do we need to radiate that to prevent future seizures? And they determined that at this point it wouldn't be necessary to do radiation in addition to any of the other sites for his cancer. They said that possibly in the future the lung portion could be, but at that point in time, chemo would be the way to go to start. And then the other big aspect is he did have a seizure, and we did have a potential focus for like a focal seizure. And so the neurology team decided to start him on zonisamide, which is a AED, and they wanted him to follow up with an outpatient epileptologist. So we made sure to get the follow-up for that in addition to his oncology follow-up. And we had multiple conversations with the neurology team, whether they thought that this was a provoked versus a focal seizure caused by the underlying brain mass. And they kind of came down to the conclusion, based on the EEG being normal, that it probably was provoked, and he maybe was more likely to have a seizure because of the mass. But they thought that it would be a good idea to start up on anti-epileptic medication just in case. The choice of the anti-epileptic drug of the zonisamide was actually an interesting one. I really hadn't heard of that as monotherapy. It actually has been shown to have benefit in partial or focal seizures. And it's actually not FDA approved for that purpose in the United States, but it is FDA approved in Europe, or I guess the Drug Administration in Europe, and multiple Asian countries. And it's kind of used off-label for that purpose very often by epileptologists. So if you see that monotherapy, it's probably because they've had a focal seizure at some point in time. And so we got him set up with all of that, and it was kind of overwhelming for him. So last kind of point is, for your cancer patients, it is really important to think about their mental health throughout this thing. And this is a really hard thing. I mean, he has 3 kids, he has a wife, he smoked, and it's sometimes easy to be like, oh, this is something that you could have prevented if you didn't smoke, but it's extremely important to be thinking about their mental health and the battle that they're about to go through if they're going to go through chemotherapy and treatment and radiation. So it's really important to get psychiatry involved, and especially if there is, at the facility that you work at, oncology psych or psych onc. There's an inpatient service at KU Med, but I know that they have a really robust outpatient system that is really good for meeting cancer patients where they're at in the trials that they're going to go through, not only for them, but also their family as they go through this. So we made sure to get him plugged in with that early on. And he seemed to really benefit from that and to kind of adjust his expectations for what was going to go on in the future and how it was going to affect his family. So it was a hard diagnosis to talk about with the patient. You know, he was doing fine up until that point, and all of a sudden everything just kind of bam, hit the wall, and he has a extremely poor prognosis cancer at that point in time. So we did finally get his path results back. The biopsy from the liver did show small cell carcinoma, and his final diagnosis, as Dr. Abebe had mentioned, it's the extensive stage small cell lung cancer is how you stage that, which is essentially extensive stage just kind of means it's outside of the primary site throughout. And so his chemotherapy regimen that he was started on was a carboplatin etoposide base with a, see if I can say it right, etazolizumab, which has shown some success. Monoclonal antibodies shown some success with small cell cancer, but you know, as we've learned, you know, small cell cancer is not an easy cancer to treat, and it doesn't have a great prognosis at this point in time currently. So talking to your patient about a 5-year survival rate that's pretty low it's a hard thing, and it's a case that will definitely stick with me throughout, because not only was it a really good for my first time experiencing like a true hypernatremia workup, but it was a good experience talking to patients about really hard realities that can come with the interesting science that comes behind them. So he seems to be doing well thus far, as last time I've checked, but he had a long road ahead for sure.
All right, what a case. Definitely had a sad ending, but lots of good teaching points on the way. So thanks, John, for spending us with that case. Thank you, Zach and Dr. Abebe, for being here and for helping us discuss. I'll go through some quick teaching points and then we'll wrap up for the night. So to start off, we kind of talked about a way to approach loss of consciousness, a framework to think about it. So we can think about like neurogenic causes such as vasovagal syncope that can happen for a variety of reasons. There's also kind of cardiogenic causes such as like an arrhythmia, any sort of structural changes, other like kind of orthostatic autonomic changes. And then there's the neuro, including seizures and strokes. And then any sort of mimics to not forget about, like hypoglycemia. But one little pearl was that if it's a sudden loss of consciousness with no prodrome, one thing to always make sure you check first is an arrhythmia. That would be one of the more common causes of a sudden loss of consciousness. Another tip was that lactate can be elevated post-seizure. So if you have an elevated lactate after a potential seizure, don't necessarily hang your hat on some sort of metabolic acidosis going on causing that lactate. Some clinically significant low sodium is primarily a hypoosmolar hyponatremia. Those are the type that really can cause the clinical symptoms that we've worried about. And that typically will be either euvolemic or hypovolemic, and each of those kind of has their own branch points about what to consider. And there's a ton of really great algorithms and different thought processes and thought maps online to be able to look at the hyponatremia branches. When we have a low sodium and a low BUN with a normal creatinine, that's kind of a telltale sign for SIADH. So if you see that pattern together, definitely check that out. Excuse my dog as I walk across my screen. If you have a low potassium in a patient with it that's otherwise unexplained, consider maybe they just don't take it in a whole lot through their diet. That's always something to consider. Not everything is some super crazy pathological medical cause. Also need to always make sure you check a magnesium if there's a low potassium, because not only can that contribute to low potassium, but that can make it really hard to replace that potassium. New seizures, you need to remember, is this a kind of a primary or a secondary seizure? That'll help kind of determine your next course of treatment if you need to get neuro involved. And then if there's any sort of reversible cause, if it's a secondary seizure, we can fix it and prevent it from happening again. Our physical exam of volume status is really not great. You can see a lot of evidence of that online. That's been a big topic, I think, on a lot of podcasts and stuff recently that I've heard. So definitely still do your physical exam, but don't hang your hat on it as far as volume status is concerned. Admitting to the ICU versus to the floor can be a big question, especially in the emergency department when you're trying to determine where should this patient really go. And a lot of factors go into that, and a lot of it is institution dependent, such as what is the ratio of the nurses to patients on the floor versus the ICU. Is your nursing staff able to handle what this patient is going to require as far as monitoring and frequency of lab draws or of neuro checks, that type of thing? Is your nursing staff prepared for that? Are they understaffed upstairs? Maybe they just can't handle that, just due to the structure of the floors upstairs. And then just what kind of resources are on the floor. You probably shouldn't have a patient getting hypertonic saline on the floor simply because that means that they're in a very tenuous situation. Or does your floor have a ton of resources and it's essentially an ICU, just not by status? So things to consider by your institution. Hyponatremia, you have to be really careful with treatment, determining if it's a acute versus a chronic hyponatremia. I think that's something that's drilled pretty well in medical school that we're taught, but always remember looking for rapid changes and or symptoms can tell you that maybe we need to treat this more acutely and give them maybe some hypertonic saline. But if there's signs from their history that it's more chronic or they're asymptomatic, be a lot more careful. We need to correct that slowly to prevent osmotic demyelination. IV crystalloid fluid, remember, it does not all stay in the vascular space. A lot of it will go into the tissues, so just remember that. You can expand the volume quickly, but it doesn't always stay there. SIADH, little pearl and normal saline bullets can actually worsen your sodium, so watch out for that. Hyponatremia, there's lots of things to think about before you send that patient home. Are they safe? Do they have a good discharge plan? What does their follow-up look like? Maybe even try a trial run of their discharge meds to make sure that they're stable on those meds before you send them out of the hospital. And finally, with a new cancer diagnosis, always remember the psychological kind of trauma that can bring and considering involving your psych colleagues with that new diagnosis. Anything to add, guys, before we wrapped up?
One thing I did want to add that I kind of had skipped over just for time purposes, there's a formula called the Adrogue-Mattias equation that takes into account a lot of things about a patient's total body water and their current sodium, and you can actually, it can help you predict how much you're going to get increase in sodium based on how much you're giving them. So that's a tool that I don't know that it's used very often, but if you're trying to come up with a initial rate for how much sodium you can expect from giving X number of liters of saline, for example, or hypertonic saline, that gives you a kind of a baseline for how you can estimate so you don't overshoot and correct too far. On the wards, I don't think I've ever seen that used. I don't think I've ever seen anyone actually say, oh, I need to calculate how many milliequivalents I'm giving this person. As Dr. Abebe is shaking his head, that's a definite no. But it's one of those things that you might get pimped on at some point in time. So just be aware that there are equations for that, but it's not super used, but you'll see it around. So
of an academic interest, I would tell you, in my 25-year experience, I've used it once, and then it took so much time that I didn't think I would use it again.
That probably goes with my researching this. So that might be my one. I don't know.
I love it. Well, for the sake of time, we'll go ahead and wrap up. Real quick, Zach and Dr. Abebe, one quick takeaway. What's something you learned or something that kind of hit you hard that you're going to take away from this case?
I'm definitely going to go look up this whole SIDH and normal saline bolus thing, and that whole pathway. I remember my first SIDH patient that we were working up, and it's complicated and can get into the weeds a lot. So those flow charts are nice if you have them.
Gotta love the flow charts. Dr. Abebe, what about you?
I think as always, I don't want to focus on one thing and be dragged into one direction. Just look at the whole picture to come up with a plausible pathway to go. So there are multiple things: young patient, sudden loss of consciousness, smoker, drinker. There are so many avenues that you could go. If you hone in on just one, you can see from this case that you'd miss the diagnosis.
Awesome. Well, thank you all for being here. This was great. Had a great discussion, and we'll call that a wrap for the night. Have a good one.